Hello and welcome to Unit 2, Part 1. We have infant and pediatric sleep studies, but why? Why do we have them and why are they important? Approximately 25% of children suffer from some sort of sleeping problem. For instance, snoring has a prevalence of 3 to 12% in preschool age children. It depends on who you ask. It's a common misconception that children will grow out of their sleep problems. Sometimes children will sleepwalk when they're feeling stressed out, and although those are usually transient events that don't occur for long, those instances could be signs of a deeper sleep problem that hasn't totally revealed itself. So through the developmental ages stages, the problems and prevalence changes. For instance, there is a rise in insufficient sleep duration in adolescents, and nightmares are more frequent in younger children. Family stress can already be critical if there are small children at home. More problems, including ones with sleep, can really make stress worse. Now, the patient and the parent aren't potentially sleeping well, and anxiety can also be a very powerful stimulant. When you're worrying about things, it's hard to fall asleep. When these patients have problems, they're usually chronic, meaning long for a long time or lifelong even. There are predisposing factors for developing a chronic problem, such as a difficult temperament, you're not very easy to get along with, chronic illnesses, you're up sick all the time, neurodevelopmental delays. It's not very polite to say it now, but when I was growing up, people would say someone was slow. Uh, Maternal depression and family stress can all have an impact on pediatric sleep. Narcolepsy and restless leg syndrome can be identified in childhood, so early intervention and treatment can be beneficial. A successful treatment would show marked improvement in mood, behavior, attention, and potentially academic performance. Primary prevention means preventing problems from even starting to develop. You won't get lung cancer from smoking cigarettes if you don't smoke cigarettes and if you stay away from secondhand smoke. That's an example of primary prevention. Secondary prevention would mean actions that are trying to keep a problem from becoming worse. If you were a smoker and developed a cough, you could quit smoking as a secondary prevention to stop this damage that's been brought on by smoking. Paxlovid could be considered a secondary prevention. Once you get COVID, you can take Paxlovid to try and prevent the symptoms from getting worse. The COVID-19 vaccination would be the primary prevention, part of the primary prevention. If parents better understand what is normal in children, they may be able to prevent their children from developing a lot of the behavioral problems they sometimes have. For instance, parents may not realize the implications of not following a sleep schedule and setting up a rhythm may have. If you understand the basic principles of what happens in the brain when children sleep, then you can imagine why when children aren't sleeping well, it's a big deal. They're losing out on development that they won't get back. Poor sleep can lead to performance impairments like impaired verbal fluency, creativity, memory, and abstract thinking. Daytime sleepiness and mood dysfunction are also associated with sleep problems. Developmentally wise, the poor sleeping child misses out on physical, emotional, cognitive, and social gains. Chronic sleep problems during these critical development periods have long term consequences on mental health and can increase accidental injuries and potentially harm the cardiovascular, immune, and metabolic system, meaning glucose metabolism and endocrine function. Sleep problems tend to be more common in children who already have chronic medical conditions. ADHD children, for instance, suffer more from their symptoms when they don't sleep well. And the same goes for those with depression. Sleep medicine is still relatively a new science, when compared to all the other specialties. We still don't know much about the brain. We know enough to be dangerous, I like to say. And right now, it's not exactly a popular idea that teenagers aren't supposed to be tired and sleepy. We think they are. Excuse me. One study showed that 20% of pediatricians don't even screen for sleep problems. A lot of parents don't even seek treatment because they might not think there is a problem. And if there is a problem, there might not be a solution. When it comes to children with sleep apnea, one study showed a 226% increase in healthcare visits. Basically meaning you got so many more, DME appointments, you got to follow up with your sleep specialist and all that stuff. OSA, or obstructive sleep apnea, and insomnia in children may appear and then disappear for a time, but then reappear later again. If the anatomy that once made it happen is still there, it can still happen again. Sometimes the way the body grows and changes can make the sleep-related breathing disorder less severe. But once you stop growing and you start sagging, that obstruction can come back. These are some figures that averages between different studies. Notice that teenagers can experience significant insomnia at 7%. Delayed sleep phase syndrome at 7%. That means they feel compelled to go to sleep later and in turn wake up later in the morning. And teenagers also have insufficient sleep at 33%. That's a third of teenagers feel they don't get enough sleep or don't get enough sleep. Bruxism is another feature that can be popular in children, grinding your teeth. There are varying results for rhythmic movement disorders, somewhere between 3 and 15%. These are like head banging or head rocking while the patient tries to achieve sleep onset. Here's a fun acronym some pediatricians will use to remember the signs of pediatric sleep disorders. And asking questions like these are better than, yes or no questions like, do you have a sleep problem? That's not going to do very much. So in bears, B stands for, do you have bedtime problems? E, excessive daytime sleepiness. A, do you have awakenings during the night? R, what's your do you have regular, and what's your, do you have regularity and good duration of sleep, I should say. And S is for snoring. If the primary care pediatrician screens for sleeping problems like this, it will increase the chances of catching a disorder in the primary care setting and increasing the likelihood that the child will get treatment for that sooner. These kinds of questions for screening are good from ages 2 to 18. Here, asking questions following the Bears guidelines looks different for different ages. Who to ask the questions will also change. In the beginning, children are less likely to be, able to accurately say what they're feeling or what they do. Toddlers are dependent upon their caregiver to answer for them. School-age children may be able to give some helpful information, and it would be pretty appropriate to ask adolescents and teenagers straight up how they're feeling. Here's what you might ask for the E. For a 2-year-old to 5-year-old, does your child seem overtired or sleepy during the day? Does he or she still take naps? You're going to ask the parent those. For school-age children, 6 to 12, does your child have difficulty waking, sleeping during the night? Or you would ask the child, do you feel tired a lot? Adolescents, teenagers, do you feel sleepy a lot during the day in school? If they're 16 or older and they drive, do they feel sleepy while they drive? So there are also for awakenings during the middle of the night, and these are just examples of questions that could be asked. Sometimes one question will lead to another. So it's not a bad idea to change them up, but and I'm not going to go through all of these because there's a lot. But if you want to go through them, you just want to make sure that everything is age appropriate. Here's regularity and duration. When you ask these questions, make sure that the parent knows what is regular for their child. It does change, and if they think their 13 to 8-year-old supposed to have toddler preschool sleep at like 14 or 16 hours, well, that's just incredibly inappropriate. So make sure that the parents stay educated on what their child needs, and you can ask questions like that. What do you think your child should how long do you think your child should be sleeping? Snoring. That's probably, honestly, that might be one of the biggest indications for really it can be ambiguous. A lot of children can snore for a lot of different reasons, but ultimately pediatrics snoring is abnormal. If you're healthy, if you don't have allergies, if you don't have something blocking your airway with an obstruction, you shouldn't be snoring. So children, that's pretty uncommon. Adults, it's common, but so it's good to keep track about things like snoring, because that can really indicate that a sleep study is needed. With all studies, you should prepare yourself for what might happen. Children may be totally fine until you start hooking them up, and then they might break down. Or some are okay until they lay down in bed with all this stuff on and figure out they're not going anywhere. There are some things that you can do to make your little patient have a better experience. You could call someone from the office should call the patient's parents and give them good information about the study. You should make sure the patient knows that there aren't any needles, there's no pain, you're not going to lose your hair, we can't read your mind, you can still get up and move around and go to the bathroom. These misconceptions can keep a child fearful, and that's the last thing you want a patient to be when you're trying to get them to sleep comfortably. Interstaff communication can also help. There are usually places and charts for notes to be left for other staff or providers. Sometimes notes can be left that let whoever know who is going to run the patients what they prefer or what to expect when they come for an appointment. Have the patient or the parent explain the procedure many times before the visit, so the child gets used to the fact that they're going to the sleep study, but it's going to be fine. A pre-visit desensitization tour can be scheduled to allow the patient and their guardian to see what's going on and that it's not so scary. If you can change the sheets or have something child-friendly on the TV when the patient is there, all the better to keep them comfortable. If you have a stash of stuffed animals or toys, you should break those out. Anything to make everybody happy within reason. Sometimes technologists are tasked with providing the patient's parents with a pre-study phone call. It's a good idea to find out what the parent thinks, how the patient feels about the study. You should reassure them by explaining the procedure and how nothing's permanent. Inquire if the parent believes that there will be difficulties either with the patient or logistics. Maybe it takes them forever to fall asleep and all this is going to make it even worse. If you have some, share tools with the parent to better prepare their child for the study. As always, you should document the phone call so everyone can see what happened and they can get an idea of what to expect. Little things like calling the sleep study a sleepover can set the child's mind at ease. I do that with the adults too. Some of them are fearful like children. If you call it a test, they might get nervous about doing something wrong. Try and mask all the clinical aspects of the rooms as possible to make it look like a night in the hotel or something. Encourage patients to bring in things that they normally do before sleep or things that they like to sleep with, like special animals or blankets. If available, written material that discusses aspects of the procedure should be given to the parents before the study. Usually, this is in a mailer because people will forget what they're told, but they can always go back to the paper and reference whatever they need to know. A pediatric centered brochure with pictures and descriptions would be very helpful. Video online would be even better. For a pre-visit desensitization, you have the patient tour the facility and show them exactly where everything is and how everything works, paying close attention to the patient's mood. If they seem receptive and interested, maybe you can play into that. If they are shy, don't talk about clinical or technical stuff. Keep it very light. Show the patient that they can trust you. Maybe have a small game you can play with them in their future study room. You can introduce the patient to the wires. Let them play with some of the old stuff that's out of commission, maybe. What are other ways we can establish trust with children? Candy can help, but you've got to have you got to make sure it's okay with the parent. And maybe you don't want to give chocolate or something sugary to a kid before they fall asleep. It might not work so well. My old lab used to have a treasure chest that children could take home prizes. Remember one thing, though. Children are all different. What may be soothing to one may be absolutely awful to another. If the lab is a dedicated pediatric lab or has rooms that can be dedicated pediatric rooms, they should have at least the appearance of a child's room. It doesn't need to be flashy or eye-catching, but try to hide the equipment behind blankets and curtains. Have inviting pictures on the walls. Have the TV on while hooking up, and for a little while after as a distraction. The room should really be pre-child proof. There's no such thing as child proof, but you should really do that before they arrive for the study. The bed should have movable or detachable side rails to prevent the patient from falling off into the floor. When watching infants, be sure to keep the sleeping area clear of blankets, pillows, or any other loose materials. Suffocation risk comes with those kinds of things. Electrical outlets should be covered with those things that are a pain to take out of once you put them in. But it'll keep people more safe, babies more safe. Try and cover any sharp corners on the side tables or furniture. Kids like to run around and they run into things, and those corners are right at eye level for small people, so we don't want anybody getting hurt. Some providers prefer to run video throughout the child's entire stay at the lab from the time they enter the room to the time they go home, and then all the sleep stuff in between. This is a great way to document how the patient interacts with the parent, what their nighttime routine might be like. It's also a way to document suspected abuse cases. You might be surprised how often people forget that they're being recorded. Emergency medical services should immediately be activated if the patient does any of the following. If they are suddenly unresponsive, having a hard time breathing, or if they're losing their color and going pale. If you notice during the study scoring apneas that are longer than a minute, that's something pretty serious. Also, although they are very uncommon in children, cardiac arrhythmias such as asystole or cardiac pause for longer than 3 seconds or ventricular tachycardia that lasts at least 6 seconds and any duration of definitive ventricular fibrillation. Again, cardiac problems in children are unlikely. Respiratory issues are more prevalent, more likely to be seen. If you notice that your patient has low oxygen saturation and you've already checked to make sure that the reading is accurate and not artifact, refer to the patient's chart to make sure it's not normal for them. If it's not, call the provider. The same thing goes for if you notice a funny EEG signal or EKG abnormality. First, be sure what you're seeing is real and not artifact. Make sure the wires are on correctly and they're plugged in the right place. Once you confirm that everything's right, respond with emergency action. All this should be streamlined through your lab's P&P, so it doesn't take you very long to do all this stuff. Also, be on the lookout for acute illnesses or sudden illnesses that are accompanied by things like nausea, vomiting, diarrhea, fever, severe headaches. Asthma is a pretty common childhood disorder, and you should expect some pediatric patients to show symptoms at night in the sleep lab. Uh, Coughing, waking up coughing is a big one. That can be pretty annoying for a sleep tech. Hearing that coughing over the intercom, it's awful for the patient, but just thinking about sleep teching too. Uh, know what to do in those situations. Is there a standing order for albuterol? If so, where is it kept? Kids can also get hurt easily. Getting their fingers jammed in the corners or the doors or cabinets. They can also choke themselves on wires or curtain strings. They can fall out of bed. Children are just dangerous. Any pediatric patient has the potential to be a challenging case, but certain negative behaviors and attitudes can be prevented or calmed with an even and steady demeanor. Typically, the younger the patient, the more challenging it can be, but it drops off a little bit. Weeks old to months old, they can't move very much, so it depends. Scanning the patient's chart is critical. Any of the entries could be indicators towards how the study may go. Look for certain medications that may cause children to stay awake or become drowsy, or medications that are usually to treat a mentally unwell child. Some physicians care for complex cases and challenging patients. Some practitioners specialize in special needs, like some neurologists specialize in cerebral palsy or autism. Endocrinologists may specialize in Prader-Willi. And any psychiatrist who refers patients, all these are potentially challenging cases due to their logistics, the behavior of the patient, or the complexity of the treatment needed. Inquire about possible hospitalizations. How did they do when they got there? After all, a sleep study is kind of like spending the night in a weird hospital. Psychotropics are drugs that act primarily on the central nervous system. It can change brain function, resulting in temporary changes in perception, hearing, seeing, feeling, mood, consciousness, and behavior. These could be painkillers, psychiatric medications, antidepressants, anti-anxiolytics, stimulants for ADHD, or antipsychotics. You know what else is a psychotropic? Is caffeine. Cerebral palsy is a term used to describe just a bunch of different neurological disorders that normally appears either in infancy or early childhood and results in permanent muscle coordination and movement disabilities. These disorders are caused by brain abnormalities in parts that control muscle movements. Depending on which area of the brain is damaged, many effects are noticeable: muscle tightness or spasticity, involuntary movements, disturbance in gait or mobility, difficulty in swallowing, and problems with speech. In addition, they may experience abnormal sensation and perception, impairment of sight, hearing, or speech, seizures, or mental retardation. Other problems that may arise are difficulties in feeding, bladder and bowel control, skin disorder due to pressure sores, and learning disabilities. Spina bifida translates from Latin into split spine. This is a neural tube defect which involves incomplete development of the brain spinal cord or their coverings, caused by the failure of the fetus's spine to close properly during the first month in utero. It's the most common disabling birth defect in the United States, and more children have spina bifida than have muscular dystrophy, multiple sclerosis, and cystic fibrosis combined. All right, that's the end of part 1. We will continue with part 2 next time. Email me or text me with your questions. I'm happy to speak to any of you. If you, I've recently gotten better equipment. If you are hearing me better, that's fantastic. If you think other things might be better if I were doing them differently, let me know. I am open to suggestions. I want to better teach you, and I want to do it the best I can. So let me know. All right? We'll see you next time.